located in the American Lung Association in the Wisconsin office. I want to welcome everybody today to the Freedom from Smoking Facilitator Recertification Webinar training. We have several different presenters today from the Upper Midwest region. We'll be covering many different topics. But before we do that, I just want to check in to make sure that we have everybody. I can see some of the names, but I know some of you are dialed in as guests, and so I'm just not able to see who they are. So I'm just going to do a quick roll, and then I'll ask also, if there was anybody that I missed. And I apologize in advance if I mispronounce your name. I see Barbara Ferrari, Barb Lynch, Kara Barker, Courtney Drummond, Diane Bartlett, Eric. And Eric, could you let us know what your last name is?
Maynor, sorry.
That's okay. Thank you. Welcome.
Oh, thank you.
We have Brittany, and that's Ingledew. Janelle North, Jane Bergman. Just going down. Jody. Jody, could you let me know what your last name is? Is it Fitzgerald? I see it now. I'm just spreading out the screen a little bit more here. We've got Lauren Collin, Lindsay. And Lindsay, what's your last name? I'll keep going here. Mike Take, Sarah Dillevin Popsel, Sarah Phylos, Scott Lalonde. Who have I missed? If you could let us know what your name is.
Mariana Roshek.
Thank you, Marianne. Who else do we have on the call? Say that again.
Bonnie Waukee.
Bonnie. Okay, and who else?
Vicki Lind.
Welcome.
Thank you.
Anybody else that we've missed?
Hi, Carrie. It's Marianne Zakaria.
Hi, Marianne. Welcome.
I'm trying to just get onto, I can't seem to get onto the Skype site, but I'm going to work on it.
Okay. Anybody else that I've missed?
Hi, Carrie. This is Erin in Mankato.
Hi, Erin. Okay. Anybody else that joined us? All right. We're going to get started. So again, I want to welcome everybody.
Carrie, do we still have you?
Hi, everybody. Sorry about that. Can you see the screen now?
It's not coming through on my end just yet, and it's asking if I want to present. Looks like something's loading. There we go. It is on the screen, but is showing your entire screen rather than just the slide. There we go.
All right, everybody can see this. Thank you. Sorry about that.
No, I can't see it yet, sorry. And I've been on the Skype site for 10 minutes. I just see me and 3 other people who are signed in as participants.
Interesting.
Mm-hmm.
If you would like to type your name into the comment box if you're not able to find the screen, then I can work on doing some triage. If you actually just type your email address, then I can resend the link to you and we'll give that a try.
Thank you, Erin.
Sure, right.
Mm-hmm.
So other people aren't seeing the screen.
So if you're not seeing the screen, are you able to comment?
Not your fault.
I was able to add my name in the conversation box, my email.
Okay, I'm not seeing that just yet.
Do I have to type in that I'm here or anything?
It almost seems as though we're on 2 separate sites. So I'm going to provide my email address, and I'm going to ask that anyone who's not able to see the screen send me an email, and I will resend you the link. It is Erin, ERIN, .Simmons, SIMMONS, @lung.org. And I will be watching for your emails to come across. And then, Carrie, you should be able to just move forward, and we'll get things resolved on our end.
All right, thank you, Erin. Well, welcome. Sorry for these complications. We're going to get this sorted out. I want to welcome everybody to the recertification today. These are the topic areas that we're going to be covering. We're going to go through program accomplishments. We're going to talk about the overview of program approach and implementation, and then walk through some of the implementation challenges and lessons learned that facilitators have reported back to us. We'll talk about some of the new emerging issues like e-cigarettes. We'll talk about the Affordable Care Act, and then also some of the new support resources that we have available. So let's just get started. I'm going to turn it over right away to Ashley Ray.
Thank you, Carrie. My name is Ashley Ray, and I am the Manager of Tobacco Control and Lung Health in the Kansas office, and also serve with the Freedom from Smoking program here for Kansas and Greater Kansas City. So a little bit of background. Nationwide, this program has reached over 1 million Americans who have wanted to quit smoking, and that's through the Freedom from Smoking program. This program began in 1981, so we have over a 35-year history now with Freedom from Smoking. Next slide, please. And we see that this program has been effective. We see that participants are 6 times more likely to be smoke-free after 1 year than those who try to quit on their own. And also, whenever this program, Freedom from Smoking, is combined with a cessation medication, we see that up to 60% of our participants report having quit by the end of the program. So that's a very large success rate, especially when compared to not using a medication or a program in combination. Next slide. We also see greater workplace outcomes whenever people quit smoking. So here we see a reduced long-term smoking-related illness and disability, as well as reduced costs associated with those issues. We also see a decrease in absenteeism, so we have more time that the employees are actually working in their jobs and being productive. Next slide. And then some of our local accomplishments. So for the 10-state region of the Upper Midwest, over the last 3 years, we have trained 765 facilitators in the Freedom from Smoking program. And we've also had over 7,295 individual clinic participants. So as facilitators, you guys are very busy, and we're very appreciative of that. And we look forward to keeping that going. Next slide. I'll turn it back over to Carrie.
Thanks, Ashley. Now let's dive into the curriculum, review some of the basics, and talk about some of the updates that have been made over the last couple of years with Freedom from Smoking. Just as a reminder, the program is designed to be delivered in 8 90 to 120-minute sessions that's spread over 7 weeks' time. We know from experience that this time frame works best to give participants the support they need to successfully prepare for and navigate their quit attempt. The program is based on the idea that smoking and tobacco use is a chronic condition that gives repeated intervention. Quitting and maintaining abstinence is a learning process. Individuals taught themselves how to smoke. They practiced so well and so long that smoking has become an automatic behavior for them, just like breathing, eating, or sleeping. So quitting then is also a process, as a lot of you know. Individuals must learn to thoughtfully manage nicotine addiction, unlearn their automatic behavior of smoking, and substitute healthy new alternatives. Because tobacco dependence is a chronic condition, Freedom from Smoking identifies quitting tobacco use and maintaining abstinence as a process in which a person cycles through multiple periods of relapse and remission before experiencing long-term lifestyle and behavior change. Tobacco dependence is explained in the program using a 3-link chain of addiction model, and this includes the biological or physical, the psychological or mental, and the sociocultural or social factors. So if we take a look at all 3 of these, the biological, when we take a look at what that really means, people who smoke or use tobacco, they have a physical reaction to nicotine and cigarettes. Nicotine decreases anxiety, it normalizes mood, it relaxes the smooth muscle. And those muscle cells that facilitate movement inside the body, such as movement of food, which is made possible by the smooth muscles. Nicotine also suppresses the appetite and increases blood pressure. It affects the pleasure center of the appetite and increases the brain, causing feelings of reward and arousal. Nicotine passes the blood-barrier brain faster than any other psychoactive drug, taking less than 10 seconds for nicotine to pass from the cigarette to the brain. And this creates a combination of effects, resulting in a greater increase of the rewarding effects of nicotine. It acts on the brain to release various chemicals, including dopamine and norepinephrine. Dopamine is linked with memory of pleasurable events and cravings. Norepinephrine is associated with alertness, concentration, and vigilance. And we know about 80% of people that are dependent on tobacco experience some form of withdrawal when they stop using. And within the Freedom from Smoking program, we refer to the withdrawal symptoms as recovery symptoms. So if we take a look at the behavioral part, tobacco products are often used as a result of environmental cues in which smoking becomes an automatic behavior. So these would include having a cup of coffee, for example, driving a car, using a telephone, and ending a meal. And additionally, tobacco is used to cope with stress and other emotions. The social part of the addiction, tobacco plays an important role in our society. It may be part of identifying with a group or a regular part of social activities and cultural practices. So based on research, people can increase their success rate if they combine a medication, which we're going to talk about medications in just a moment, with a program. And that would be except under special circumstances. For example, people who smoke less than 10 cigarettes a day, anyone under the age of 18, unless advised by their doctor, or pregnant or breastfeeding women, and people with certain medical conditions. Remember, quitting's a process. Research states that in any given population of people who are using tobacco, 40% of them are not ready to quit. It doesn't mean that they're never going to be ready to quit. It just means they're not ready to quit today or tomorrow, maybe in several months. Another 40% of people who use tobacco are thinking about quitting. And that means, again, it might not be today, but they might be ready in a month. And then 20% are ready to quit right now. They're ready to join a group, talk to somebody about it. They're investigating ways. So quit day is a target quit day. And it's important to remember that not everybody's ready to quit at the same time. Within the Freedom from Smoking program, our target quit date, if you remember, is on week 4, session 4. So we're here for support. And no matter what happens, even if people slip or relapse, we want them to come back to the program. We definitely want people to continue attending. There's a lot of information and support that they're going to continue to receive. And then overall, looking at the program, small group settings. We say up to 16 people, really offers that personalized attention and peer support. This allows for a variety of personalities as well as a strong environment to support them. Each participant can be aware of other individuals who smoke and are part of the joint effort. So if an activity in the session calls for small group, you can divide the group evenly, and this allows for more participation from everyone. All right. So what's new with some of the program materials? We've got, in June, there were several new topics that were added to the FFS participant workbook to address some of the emerging issues. So please be sure you're using these updated materials. These can be available, or they are available, on the FFS Facilitator website. If you don't have access and are looking for those, you can contact your local contact, or you can email me directly and we can get you connected. Due to the changes in available technology, many participants are requesting the relaxation CD to be offered in a downloadable MP3 format. So that's what you're seeing on your screen right now. We've updated our material order forms, which you'll see after this webinar. We'll be emailing those out to you. So this is an option. You can get an e-card, and here's how it works. You receive the access codes that you hand out to individuals. Each access code card is personalized with a unique code and instructions from downloading the file from our digital download center. The end user downloads this file using his or her unique access code, and once the end user enters the access code at the digital download center, he or she has 30 days to download the file before the access code expires. And the MP3 files may be downloaded up to 6 different devices. So this is an option. The relaxation CD is still available, but we also have another option for you. All right. Other new programs. So again, there were some new topics added. It doesn't mean that you have an outdated version of the facilitator guide or that you need a new one. Again, a lot of these resources can be downloaded right off of the Freedom from Smoking Facilitator website. So we've included things like talking about e-cigarettes with participants, quit smoking benefits of the Affordable Care Act. Is there a safe tobacco? Can e-cigarettes help you quit? All of these things have been added. And again, if you aren't able to access the Freedom from Smoking Facilitator website, let your local contact know and we will be sure to connect you. Another new program is our Freedom from Smoking Plus program. This was launched in late 2016. And we used to have a Freedom from Smoking online program, and this new Freedom from Smoking Plus is the new online plus telephonic option of a program. So there's a little bit about the program, 9 highly interactive sessions that are split into 3 phases: getting ready to quit, quit day, and staying smoke-free. What's nice about this is it works on a desktop, tablet, or smartphone anytime, anywhere. So if somebody's accessing the program at work and then later wants to do some more at home off of their mobile device, they're able to do that and it will pick up right where they left off. There's fully updated activities that are engaging, and it includes the integrated telephone and online chat support from the American Lung Association's expert tobacco cessation counselors at the American Lung Association helpline. So after today's webinar, we will do a follow-up email, and I'll include additional information on the Freedom from Smoking Plus program. Additional resources, the Quitter's Circle. This is an effort that can complement your efforts as a Freedom from Smoking facilitator. The American Lung Association and Pfizer designed and have partnered together to launch this Quitter Circle. It's a mobile app and online community designed to help tobacco users face common obstacles associated with quitting through educational, social, and financial support. So this is not a program, but more of a support piece that folks can access. And it's both for the person that's trying to quit or going through the quit process, and also for those that are wanting to support the individual. All right. Any questions? And again, after today's webinar, there'll be a follow-up email with some of the additional resources and information as well. All right, I'm going to turn it over to Laura Turner to talk about implementation challenges and lessons learned.
Thanks, Carrie. Am I coming through okay? Make sure I'm not on mute.
You are coming through.
Okay, great. Okay, so I want to move on to some frequently asked questions that a lot of facilitators deal with that have come up through our yearly facilitator surveys and some other just conversations we've had with facilitators. So I think you might, these might ring a bell with some of you. So we're going to kind of talk through those and talk about some solutions and things that really have worked as well. We can switch the slide. So this is just kind of an overview of kind of where the general feedback that we've gotten from our facilitators has fallen in kind of major categories. So we've got a lot of people who have talked about issues with low enrollment and retention, keeping people in the class. And then also a lot of people, a lot of you who have had people who are lacking motivation to quit for various reasons. And then the other category is just kind of various different reasons, like participants wanting to use different tobacco devices like e-cigarettes, which is going to be addressed later in this webinar, so I'm not going to talk about it here. And others might be uncomfortable with the worksite location where it's often offered. And then some facilitators didn't have any problems, so that's always great to hear. But just so you know, there's kind of a general theme, and it's not just you. A lot of people struggle with the same things, and so we're going to deal with that together. Next slide. Okay, so these are just some thoughts on experiencing enrollment issues, and so this, I just wanted to say that this is something that many facilitators struggle with, and it's something that comes up a lot. So I just wanted to ask you, just kind of, I don't know, I wish we could do a show of hands, but can any of you kind of relate to this, or have any of you really had an ongoing problem with low enrollment that you've been dealing with?
And to unmute your phones, you can push *6.
Okay, so, we got somebody?
Jackie Clusie.
Hi. Oh, okay.
Let's go with Jackie first.
We've noticed that we've offered several community events for the hospital. Barb Masters and I work in a hospital, and Marcela Sanko is also a trained facilitator. But all of our community offerings, and we've had several, and we've had to cancel them just for lack of involvement on those. And we've kind of had some meetings amongst ourselves just to see how we can increase that interest.
That's good. So do you think do you feel like you have a good action plan to build on what you've done before and get more people enrolled?
Well, I think we're continuing with this. We're going to continue the offerings in the event that we have somebody, people that are willing to come. We've had some comments that people don't want to commit to the 8 weeks of coming.
Oh, yeah.
And because it is a commitment. So we were kind of looking at that to see if there's any way we can try to draw them in, at least to get them to those first few meetings, and then see where, to keep them involved in that.
Mm-hmm. Right.
We've just the focus has been really on getting it out to the community with advertisement and making them aware it's there.
Yeah, and a lot of this, I think you're doing the right thing. A lot of what we need to do is continue just being consistent so that people know that when they're ready to quit, when they're ready to commit to it, that there is a program there to help them and they know where to go. I think that's really important for people to have that availability. And then also to let them know that it is a big time commitment, but there are good reasons why it's offered for that long, and that's what research shows works the best. So, and I know people have other things going on in their lives that it just might not be the right time for them. But there are some other options that are available for kind of people who might not have as much ability to commit to a long term. So just in interest of time, we're going to keep moving. Thank you for your feedback. So another thought is that one of the reasons that you might have low enrollment is because people might not always be in the stage of change where they're ready to quit. They might have thought they were more ready than they actually are, and they kind of realize that once they're faced with the need to really work through it, and all, realizing that it is a difficult process. It takes a lot of commitment. Although there is a lot of support, but there's a lot of it they have to do themselves. So that is something to keep in mind as well, that it's not necessarily you as a facilitator, but it could be very well just where they're at. But I gotta emphasize just being present, being available, and letting them know that you're there when they're ready. Next slide. So here's some thoughts on participant recruitment, just to address the concerns with low enrollment. Starting early, and I think to add to that, just kind of keeping on with it, being consistent. You can let your local American Lung Association office know, and it can be put on our website. And there's also a way to enter that yourself to go to our website, which we'll get into later. You can talk to your local health department, and you can work together with them, maybe to recruit from there, or even see if they can be held on site at the health department. Get referrals from medical facilities, physicians, medical providers in the community. Distributing flyers, I think that does work still. So it's definitely worth doing. Sending email announcements if you're doing it within a company or somewhere where people get emails from you on a regular basis. Posting to social media, and promoting it in community newspapers and newsletters, because you never know where someone's going to come across that and pick it up at just the right time. Next slide. Another thing that we found with the feedback from our facilitators is that there are sometimes participants who really have a low motivation to quit. And there were a couple of reasons that really stuck out. Mainly, the one that I want to focus on is that there are people, when their companies are offering a reimbursement on their insurance premium if they go through a program like Freedom from Smoking. And that's the main reason they're going through the class, but they're not necessarily internally ready to quit. And that can make it very hard to engage people who are motivated to quit. Have any of you had this issue with any of your participants? Anybody who's motivated more by the money or some other external reason, but really doesn't have that internal motivation yet?
Barb Lynch.
Yeah, thanks, Barb. What's your experience?
I have had a number of companies that have this issue. And what I've started to do now is to not necessarily break them into individual groups, but as I'm talking, maybe have the people that are just there for the insurance make one positive change in their smoking. And I've found that after we go through a couple of classes, a lot of people that had no intention of quitting are really interested in making some kind of a change. So it might be they won't smoke in their car anymore, or they won't smoke around their kids or their grandkids, or some kind of a positive change by the end of the class, and that gets them more involved, and then it's easier to work with the participants who really are there to quit.
Yeah, that is awesome, Barb. I totally agree with that. I mean, you're getting at some kind of motivational interviewing skills and focusing on what's relevant to them at the moment. And that's definitely going to make people more engaged. So I think that's a great idea. And I'm glad that that has started to work for you. And other options, maybe if someone really is kind of holding back the discussion or just really not in it, but they want to check off the boxes. You know, we have other programs that are kind of more condensed, like the self-help guide. That might be something that they could go through on their own, but not really. Maybe they can go through it, you know, at their own pace, and kind of more in a way that's relevant to them. But yeah, I think your idea is wonderful, and I would definitely echo that. So we're going to move on to the last slide, if we could get that. So just some great feedback we got from many of you other facilitators as well. Here's some things that have been working well across the board for people. Using other formats when needed, like I mentioned, the self-help guide or maybe the Freedom from Smoking Plus, which you'll hear more about shortly. Coping skills has been gotten some strong feedback, as well as relaxation exercises. And really the social component of FFS is a big one. Just having that buddy system and the interaction and really getting to know the participants and them getting to know each other. And facilitator skills as well. Just really honing those skills that you learn in the training, but that you're able to build as you go on and continue with leading these groups. Nicotine replacement therapy really helps a lot of people. It's clinically sound. It's shown to increase people's odds of quitting. And then other activities as well, such as kind of additional, reading motivational articles about quitting smoking, etc. So we're going to move on to the next part, and I thank you for your feedback, those of you who shared.
Thank you, Laura. In this next section, we will take a look at some of the hot button and emerging issues in tobacco control nationwide that are affecting the way cessation services are really provided. So these are the topic areas that we are going to cover in this next section. So let's start with the Affordable Care Act and what's covered. The Affordable Care Act requires many health insurance plans to cover all preventative services given an A or a B rating by the U.S. Preventative Services Task Force. Tobacco cessation for adults has an A rating from the United States Preventative Services Task Force, meaning they recommend the service and there is a high certainty that the net benefit is substantial. However, the USPSTF, or the United States Preventative Services Task Force rating and related recommendation was written for healthcare providers, not as a model for insurance coverage policy. As a result, there have been many questions since the Affordable Care Act implementation began in 2010 about what plans are required to cover for tobacco cessation. In May 2014, several federal agencies issued a joint frequently asked questions guidance document translating the United States Preventative Services Task Force recommendation into insurance coverage policy. The guidance stated that the government would consider the relevant health plans to be in compliance with the preventative service requirement for tobacco cessation if they cover, for example, screening for tobacco use, individual, group, and phone counseling at least 10 minutes per session, all FDA-approved tobacco cessation medications, which is prescription and over-the-counter when prescribed by a healthcare provider, at least 2 quit attempts per year, 4 sessions of counseling, and 90 days of medication per quit attempt. No prior authorization is required for treatment, and no cost sharing is required. So this should mean that Freedom from Smoking program qualifies as a tobacco cessation treatment as a preventative service. Unfortunately, there still is considerable confusion about coverage for those benefits. And there was a follow-up frequently asked question released this last fall, which posed more questions than it answered, creating additional barriers and burden for those seeking assistance to quit smoking. So still very confusing. All right, I'm going to turn it over to Dominic to talk more about our medications.
Hi, my name is Dominic Palazzolo, and I'm a registered pharmacist, and I work with patients on the helpline at Springfield, Illinois. Of the 7 FDA-approved medications that are used for tobacco cessation, there are 2 oral medications which can only be dispensed with a prescription. And these are Zyban, known generically as bupropion, and it also has the brand name Wellbutrin, and Chantix, known generically as varenicline. Now, Zyban was originally marketed as Wellbutrin and is used primarily as an antidepressant. However, after several months of use by physicians on their patients, it appeared that the physicians were noting that their patients were quitting smoking without any encouragement from them. So it became apparent that a side effect of bupropion was smoking cessation. The manufacturer, GlaxoSmithKline, chose to also market Wellbutrin under the name of Zyban as a smoking cessation product. Zyban then is a type of antidepressant that also acts as a stimulant. It is a norepinephrine and dopamine reuptake inhibitor, an NDRI. The exact mechanism by which Zyban enhances the ability of patients to cease from smoking is not really known, but it's thought to be related to its relationship with norepinephrine and dopamine. Treatment with Zyban should be initiated before the patient's planned quit day while the patient is still smoking, because it takes approximately 1 week of treatment to achieve steady state blood levels of bupropion. The patient should set a target quit date within the first 2 weeks of treatment with Zyban, and treatment with Zyban should be continued for 7 to 12 weeks. Insomnia is a common side effect with Zyban, and it might be best to take the last dose of the day around 6 p.m. or several hours before bedtime, and it can be taken with or without food. The second oral medication is a tablet known by the name of Chantix, generically varenicline. It comes in 2 strengths, 0.5 milligram and 1 milligram. In a 2009 meta-analysis, varenicline was found to be more effective than bupropion. A 2013 Cochrane overview and network meta-analysis concluded that varenicline is the most effective medication for tobacco cessation, and that smokers were nearly 3 times more likely to quit on varenicline than with placebo treatment. Now, varenicline was more efficacious than bupropion or the NRTs, the nicotine replacement therapies, as effective as combination NRT for tobacco smoking cessation. Now, Chantix has not been tested in those under 18 years old or pregnant women, and therefore is not recommended for use by these groups. Mild nausea is the most common side effect. Other less common side effects include headache, difficulty in sleeping, and nightmares. Rare side effects reported by people taking varenicline compared to placebo include change in taste, vomiting, abdominal pain, flatulence, and constipation. During clinical trials and post-marketing, there have been reports of seizures in patients treated with Chantix. Some patients had no history of seizures, whereas others had a history of seizure disorder that was remote or well controlled. In most cases, the seizure occurred within the first month of therapy. So advise patients to discontinue Chantix and contact a healthcare provider immediately if they experience a seizure while on treatment. Now, there have also been post-marketing reports of patients experiencing increased intoxicating effects of alcohol while taking Chantix. Some cases described unusual and sometimes aggressive behavior and were often accompanied by amnesia for the events. Advise patients to reduce the amount of alcohol they consume while taking Chantix. There might also possibly be a relationship between existing cardiovascular disease and Chantix, but this is still being investigated and is at this point not thought to be serious. Nonetheless, a patient with the cardiovascular disease should be monitored by his physician and report any worsening of their condition. Now, a 2014 systematic review did not find evidence of an increased suicide risk. Other analyses have reached the same conclusion and found no increased risk of neuropsychiatric side effects with varenicline. No evidence for increased risk of cardiovascular events, depression, or self-harm with varenicline versus nicotine replacement therapy has been found in one post-marketing surveillance study. Now, in 2007, the United States Food and Drug Administration had announced that it had received post-marketing reports of thoughts of suicide and occasional suicidal behavior, erratic behavior, and drowsiness among people using varenicline for smoking cessation. Then in 2009, the FDA required varenicline to carry a boxed warning that the drug should be stopped if any of these symptoms are experienced. Then in 2016, just last year, the FDA removed the black box warning. People, however, are still advised to stop the medication if they notice any side effects on mood behavior or thinking. Very basically, Chantix's mechanism of action is that it binds to the neuronal nicotine receptor sites in the central nervous system and prevents nicotine from binding to those sites, thus preventing nicotine from exerting its effect. The patient should set a date to stop smoking, then begin Chantix dosing 1 week before this date. Alternatively, the patient can begin Chantix dosing and then quit smoking between days 8 and 35 of the treatment. Chantix is to be taken orally after eating and with a full glass of water. The last 5 products are all nicotine replacement therapies. They're called NRTs. The bottom line with them is that they put nicotine into our bodies by some route to replace the nicotine that was provided by the tobacco product, which was taken away. Now, these 5 products are patches, lozenges, gum, oral inhaler, and nasal spray. Now, the last 2 forms, the oral inhaler and nasal spray, require a prescription. The non-prescription nicotine replacement therapy products cannot be sold legally to people younger than age 18. A doctor, however, may prescribe one of these products if a person younger than 18 is dependent on nicotine.
Thank you, Dominic. Thank you. Let's talk about some additional resources related to the Affordable Care Act. On our website, lung.org, there is an area that provides a lot of additional information on tobacco cessation and the Affordable Care Act. Many resources are being added all the time, so it's worth checking back periodically to see what is new. Some of the information that's available includes which plans cover which treatments to quit smoking, important Affordable Care Act milestones for tobacco control, helpful resources for tobacco control advocates working on Affordable Care Act issues, and helpful resources regarding the Federal Affordable Care Act tobacco cessation guidance. So again, these can be found on our website at lung.org, and then it's under the ACA toolkit. So as you can see, fact sheets, tools, there's presentations, maps, and help for smokers on choosing the right plan. Reimbursement for cessation services. For those of you who may be interested in billing insurance for Freedom from Smoking program participants, here are some excellent additional resources for you. Those listed under general coding/billing information and resources review insurance coverage for medications, individual counseling, group counseling, and phone counseling. The American Academy of Pediatrics maintains a list of all billing codes, and an overall review of everything smoking cessation reimbursement from A to Z can be found in a reimbursement guide that was developed by Professional Assisted Cessation Therapy. A lot of people ask which types of providers are able to bill insurance for group cessation. Unfortunately, here again, there's no general answer that encompasses all insurance plans. The list of eligible providers is determined by the insurance provider, so this is something that you will need to check out individually. All right, and I'm going to turn it back over to Dominic to talk a little bit more about pharmacotherapy.
Well, although the Freedom from Smoking program provides the information you need to give a brief overview of all the FDA-approved medications to help participants decide which option may be best for them, many facilitators, particularly those working in healthcare settings, have expressed interest in more in-depth guidance for talking to participants about the proper use of pharmacotherapy. Studies suggest that all people trying to quit smoking should use effective cessation medications. People who use cessation medications in addition to behavior modification counseling to quit smoking may double or possibly triple their quit rate. Many patients misuse the nicotine replacement products and become discouraged because they are not obtaining the intended effect. Now, there are both prescription and over-the-counter pharmacotherapy options, 5 that contain nicotine and 2 that do not. Next slide. Now, people become dependent on the nicotine in cigarettes because it increases the levels of certain chemicals, such as dopamine and norepinephrine, in their brains. When people quit smoking, the levels of those chemicals drop. Their bodies react by having nicotine withdrawal symptoms, such as grouchiness and hunger, or maybe even worse. Nicotine replacement medications deliver nicotine to the body differently than cigarettes, and this results in a slower delivery of nicotine. With the NRT products, chemical levels in the brain are kept level so that withdrawal symptoms are reduced, and this can temporarily replace the nicotine that a person got from smoking cigarettes. Nicotine replacement can be used in smaller and smaller amounts until a person no longer needs it. Now, this graph from Mayo Clinic shows how the use of these medications can reduce the recovery symptoms experienced by the patient. The yellow area shows the recovery withdrawal symptom. Now, this will peak in intensity through the first few days. The red lines represent the urges and cravings experienced, and those urges become less frequent and less intense as the days go on. The green lines represent the nicotine replacement product. The large green area showing a long release shows a long release NRT, such as the patch, and the smaller green bumps represent an immediate release nicotine replacement, such as the nasal spray or the inhaler. Nicotine replacement therapy is useful for most people who are trying to quit smoking. However, it may not be right for you if you are pregnant or have heart disease. Nicotine replacement therapy has been shown to be safe in most people with heart disease, but if you recently had a heart attack or if you have serious heart problems, such as an irregular or rapid heartbeat, which is known as an arrhythmia, or chest pain, which is known as angina, consult your doctor before you use nicotine replacement products. All forms of nicotine replacement have side effects, but the types of side effects differ across the board with the different nicotine replacement products. The NRT gum may cause a bad taste or a tingling feeling in the mouth, hiccups, or upset stomach. Lozenges may also cause hiccups and upset stomach. The patches may cause a skin rash at the application site and or sleep problems such as insomnia or vivid dreams. And this problem can be solved by removing the patch 30 to 60 minutes before going to bed. Next slide. Now then, using some form of nicotine replacement therapy doubles your chances of quitting smoking. All forms of nicotine replacement products appear to be about equally effective when used properly. Pharmacotherapy is usually recommended for at least 12 weeks. Heavy smokers may need to use higher doses of the nicotine replacement. And combining the use of the nicotine patch with another form of nicotine replacement therapy, such as the gum, increases your chance of success. But you need to talk to your doctor before combining the nicotine replacement therapies. Those at high risk of relapse may stay in treatment for 6 months or more, and that would include those with persistent, strong urges to smoke, those with a higher dependence or with past substance abuse, and those with comorbid medical or psychiatric illness, or those who were unable to quit on their target date. The patches, which are probably the most popular of the nicotine replacement products, are available in 3 strengths: 21 milligram, which replaces about 1 pack of cigarettes, 14 milligram, which replaces about a half a pack of cigarettes, and 7 milligram, which replaces about a quarter of a pack of cigarettes. The NRT gum and lozenges are available in 2 and 4 milligrams. The 2 milligram replaces 1 cigarette, while the 4 milligram replaces 2 cigarettes. Your chances of quitting are best when you combine nicotine replacement therapy with a complete smoking cessation program that includes setting a quit date, having a plan in place for dealing with smoking triggers, and getting support from a doctor, counselor, or support group.
Thank you, Dominic. This is Erin Simmons. I'm based in southern Minnesota. I have not spoken with Dominic in the past, and after hearing him talk, I'm kind of hesitant to follow him because you have such a nice voice. So next we're going to talk a little bit about electronic cigarettes. And I think it's great that this follows talking about pharmacotherapy, because the most frequently asked questions that I receive around what types of medications folks can use is, well, why couldn't I use an electronic cigarette? People might ask questions about harm reduction. Isn't this safer? So wouldn't it be better if I did this? And I think the most difficult question that I answer is, we don't know much about it, so why not give it a try? The evidence isn't necessarily there that there are long-term health consequences. So what I want to do today is focus on the things that we do know. And I think one of the most important things that are helpful things that I share with folks is that we know that our lungs are only made to breathe clean, pure oxygen. And so when we're inhaling another drug or chemical on a regular basis, then that's likely to cause damage to our lungs. So other things that we know, electronic cigarette usage is expanding rapidly, particularly with our young adult and youth population. E-cigarette manufacturing companies are using marketing tactics and messaging that they've already used with other products here in the United States, and they're heavily targeting our youth through those strategies. Electronic cigarettes are not proven as an effective cessation device, but they're often promoted as such. In spite of these and other concerns, it wasn't until 2016 that the FDA announced a process to regulate electronic cigarettes called a deeming regulation. However, that takes about 3 years to be implemented, so we have another year left before, or excuse me, 2 years left before those rules will be fully implemented. Electronic cigarette manufacturers will be required to register with the FDA, and then they have an additional 2 years to submit an application to remain in the marketplace. Until that time, there are more than 500 brands with more than 7,000 flavors of e-cigarettes that will remain on the market before the FDA is fully able to evaluate them. Until the FDA's evaluation is done, there are very few ways for anyone other than the manufacturers to know what chemicals are in the e-juice or e-liquids and how they might affect our long-term health, whether it's short-term or in the long term. All right, so next slide, please. What is an electronic cigarette? This slide shows a variety of different designs that we see out and about. The top center design is the initial design that we saw in the community, which left us feeling like maybe this isn't going to be such a big deal. But if you look to the vape pens on the right, you can see that they now come in many different colors, shapes, and sizes. They also come in different varieties of battery power that makes it start to feel a little bit more like expertise or specialty product. And I think that that can help lure folks into their use. Next slide. Perhaps most concerning to us as the American Lung Association and to myself as a parent is the increased use amongst our youth. We know here in Minnesota that youth are now using electronic cigarettes more frequently than their cigarettes. This is concerning, especially concerning because many of the young people who are using these products are not using other chemicals or participating in other risk behaviors. So it feels like this might be something that they don't see as a risky behavior because it is fruit or candy flavored or because they're being told it's not harmful to their health. they might be hearing things like it's just water vapor. The last bullet on this slide indicates Poison Control Center calls. This is also concerning as a community member and as a parent because we're seeing those calls increase dramatically. Again, this is a product that tastes like fruit or candy. Some people have compared it to the taste of a flavored chapstick. It's not until the product has been ingested that a child would feel the negative impact, unlike perhaps smoking a first cigarette where there's an immediate negative consequence to that. Depending on the amount of nicotine in the e-juice bottle, it takes only 1/3 of a bottle to poison a toddler, so it really amounts to one good swig of the e-juice would be enough to cause a negative health effect. Next slide. We know that electronic cigarettes have a number of potential health impacts. In addition to the nicotine addiction, there are things that we hear about like popcorn lung. Health consequences of use of electronic cigarettes and exposure to secondhand e-cig emissions are still unknown. There is not scientific evidence establishing the safety of electronic cigarettes. Of course, we do know a lot about nicotine and can assume that the impact of nicotine in electronic cigarettes is similar to that of regular tobacco. Almost all e-cigarettes contain nicotine. Even some products that claim not to have any nicotine in them may still contain nicotine in it. Again, this would make cessation through this product very difficult if we do not understand the amount of nicotine that we're utilizing. Initial FDA lab tests conducted in 2009 found that cartridges labeled as nicotine-free had traceable levels of nicotine. A 2014 study found the amount of nicotine in e-liquid refills is often substantially different from the amount listed on the package. Nicotine is not safe. The U.S. Surgeon General has found exposure to nicotine during pregnancy harms the developing fetus and causes lasting consequences for the developing brain and lung function in newborns. Nicotine exposure also affects maternal and fetal health during pregnancy and can result in low birth weights, preterm delivery, and stillbirth. Nicotine also has a negative impact on adolescent brain development. Nicotine use during adolescence and young adulthood has been associated with lasting cognitive and behavioral elements, including effects on working memory and attention. Flavors in e-cigs are also cause for concern. Not only are flavors used to target kids, but they might be harmful all on their own. Electronic cigarettes and flavor manufacturers and marketers may suggest that the flavor ingredients used in e-cigs are safe because they've been approved for use in food. So they might say things like, this is food grade propylene glycol. But such statements are false and misleading since they've not been tested for safety when inhaled. One common flavoring is diacetyl, which is a buttery flavored chemical often added to food products such as popcorn, caramel, and dairy products, and has also been found in some electronic cigarettes with flavors. This is known to cause serious and irreversible lung disease, commonly known as that popcorn lung. It will be years before we have a good understanding of the potential long-term health effects of electronic cigarettes, such as cancer, COPD, and heart disease. But I often remind our decision makers that we can apply common sense and the information that we've gathered over the years on other products that are frequently inhaled. The other health impacts that I want to note are fire and explosions. You might have heard of these devices exploding or blowing up. Recently I heard about an attorney who was trying an arson case and had an electronic cigarette start a fire in his pocket. I thought that was a bit ironic. But this is sometimes happening because they continue to charge. So some of the batteries in the e-cigs do not have a shut-off, and so they'll charge and charge and charge until they will explode. Next slide, please. So I mentioned earlier that we do receive a lot of questions about electronic cigarettes being a possible cessation aid. There are some really key reasons why that is not known to be effective and should not be advised to those wishing to quit. We don't know that these are a safe product. When the FDA attempted to take a look at the safety and the use of electronic cigarettes back in 2009, they were sued by the tobacco industry saying, no, we're not a cessation device. And they won that lawsuit. But sure enough, as they became labeled a tobacco product as a result of that lawsuit, now they want to advertise themselves as a cessation device. So we don't know those long-term health effects. We have no evidence that they are successful. In fact, oftentimes, anecdotally, I hear that folks try using an electronic cigarette to help them quit smoking. It doesn't work, or they don't feel satisfied in using it. And when they go back to smoking cigarettes, they're finding themselves even more addicted than they were before. Next slide. This is a position or a policy statement from the American Lung Association on electronic cigarettes. Just to note that we do support including electronic cigarettes in smoke-free laws and ordinances, both state and local policies. We support state laws that prohibit the sale of any flavored electronic cigarette products, again, because these products are being marketed heavily to our kids. We do support taxing electronic cigarettes as a rate equivalent with all other tobacco products, and that is because we know that by keeping the price of tobacco high, we can help reduce use and initiation. We support eliminating electronic cigarette sales to youth, otherwise restricting youth access to electronic cigarettes, and requiring electronic cigarette retailers to be licensed. We oppose creating new definitions for vapor products and alternative nicotine products in state laws or local policies. And we do believe that electronic cigarettes should be defined as a tobacco product. At this time, I'll open it up for any questions that you might have. Again, *6 to unmute yourself. All right, we'll move on to the next slide then. I think we need to go one more. As a reminder, we do have a number of resources that are available to you as a facilitator. The first that I'll mention is the FFSFacilitator.com website. Here you'll find program materials such as facilitator scripts, videos that you might use during the class or as a way to educate folks about the opportunities that you have. Facilitator forms are also available on this website. You'll see program updates here. This can be especially helpful. We saw this with the introduction of electronic cigarettes, a great place to go and get information on new products. Marketing support, it's a way to let others know about the programs that you have coming up. Industry news and related links. And then I'll also mention that if you do not have access to FFSFacilitator.com, you can reach out to your local lung association staff, or you can email gethelp@cramestaywell.com, and we will be sure that you have access to that. Next slide. This year, we've made some significant enhancements to the program promotion and recruitment materials that are available to facilitators. These resources include a listing of Freedom from Smoking clinics on lung.org, which is our organization's website, rack cards and flyers, announcement postcards, templates of recruitment emails and texts, and facilitator business cards. Again, you can find these materials at FFSFacilitator.com or reach out to your local lung association contact. Next slide. Each of you should be receiving the Freedom from Smoking Facilitator Coaching newsletter the first week of each month. If not, again, please reach out to us and let us know. We want to be sure that you're on this list. This newsletter includes a hot topic of the month, what's going on in your state, resources from ALA's national office and within your state, contact information for questions, and a Did You Know tip. Next slide. Now I'm going to turn things back over to Ashley Ray. Thank you all again for joining us this afternoon. We'll have more time for questions at the end of our presentation.
Thank you, Erin. This last session, we are going to briefly go over the facilitator agreement. And you should have all received a copy of the current Freedom from Smoking Facilitator Agreement already. And this form reviews what the American Lung Association agrees to provide to all facilitators and what you, as the Freedom from Smoking Certified Facilitator, will agree to uphold when delivering the clinics. Again, you need to sign and return this new agreement to your state staff in order to be certified to deliver the Freedom from Smoking program. And this new agreement will be good for a period of 3 years. And I'm going to briefly go over some of the high points in the facilitator agreement just as a refresher. So the American Lung Association will agree to promote the location and contact information for your clinics that are open to the public on our website. We'll also provide the undersigned facilitator the tools and resources to assist with conducting the FFS group clinic. This includes the facilitator manual, the participant workbooks, the program logos, the template promotional materials, and attendance and evaluation forms. Also to promote the freedom from smoking and raise awareness of the importance of tobacco use prevention and cessation through both local and national communications and marketing efforts. And those are just a few of the roles and responsibilities of the American Lung Association. Some of the roles and responsibilities listed on the agreement for the Freedom from Smoking Certified Facilitator include, but are not limited to, assert that he or she is and shall remain tobacco-free and has not used any form of tobacco in the last 12 months. This does include electronic nicotine delivery devices or e-cigarettes. So again, you cannot have used tobacco products in any form or e-cigarettes in the prior 12 months, and you certify that you will remain tobacco-free. Another role and responsibility is to conduct at least one Freedom from Smoking clinic in the first 2 years of your certification period. To also adhere to the American Lung Association guidelines for setting participant registration fees. To adhere to the content and format of the FFS clinic programs authorized by the American Lung Association and use only the copyrighted Freedom from Smoking program materials. To also refrain from copying or reproducing any of the Freedom from Smoking training and facilitation materials and not to share those materials with anyone who is not a certified Freedom from Smoking facilitator. We ask that you complete the electronic annual Freedom from Smoking Facilitator Survey at the completion of each of our fiscal years, and that usually comes out in June or July, and to seek written approval from the American Lung Association's national office before entering into any research project involving Freedom from Smoking or any of the clinic participants. Again, just to high points on the facilitator agreement that you should receive and will probably receive an additional copy in the follow-up email. Can I get the next slide, please? The other part that I want to discuss is the ordering of materials. So we have a pre-clinic order form that is available and that needs to be filled out prior to your Freedom from Smoking clinic and returned to your state staff. And this is to order the Freedom from Smoking participant workbook and the CD or MP3, whichever your clinic is going to be using. And this form will again be attached to the follow-up email and return to your state staff prior to the beginning of your next clinic. Next slide, please. And then we have the ability to list all of your Freedom from Smoking clinics on lung.org. So we're able to offer this new way of promoting your clinics to those that are open to the public on our lung.org website. So for each clinic you offer, please send your local lung association contact your details as far in advance as you can. By providing us with plenty of advance notice allows time to get your clinic page built and gives the people in your community looking for a quit smoking program time to register and plan their schedules. Also, please note that we will build these pages even for clinics that are closed to the public, so such as worksite programs, and you can still get a link to the page to share with your potential participants, but it will not appear on the actual website. And then creating these clinic pages has added the benefit of streamlining reporting. So the Lung Association will be able to easily track the number and location of clinics being offered through this process. And you as a facilitator will be sent a link to an online version of the required end of clinic report form. Next slide, please. So with that evaluation and end of clinic reporting, that form helps us to see our reach and our impact from our Freedom from Smoking program. So it shows the number of clinics, the number of participants, the demographics of the participants, and the end of clinic quit rate. There's also an annual facilitator survey that helps us to make improvements to the program to be able to better serve you as a facilitator. So when you sign your facilitator agreement, you're making a commitment to certain reporting requirements. And again, we're trying to keep those as streamlined and easy to do as possible. And all of these pieces of information that we're asking from the facilitator on each of the clinics is what helps to ensure that our Freedom from Smoking program is both effective and impactful. And again, the end of clinic report form is now a brief online survey that each facilitator is expected to complete. It includes questions about the size and demographics as well as the success rate of your participants to again help us maintain the reach and impact of our program. And we will also send out an annual survey to get your feedback on your programs and experience as a facilitator. And if you have not completed these surveys in the past, we do hope that this year will be different, as we really do want to hear from each of you on your successes and on your challenges. Next slide, please. So with that, I will open the floor for questions. And Carrie, would you like to help facilitate Q&A?
Yes, thank you, Ashley. Let us know overall if you have questions. I know there were a couple that were coming in through chat, and some of those, we will definitely follow up on directly. If it pertains to the workbook, I know there was a chat question that just came in. If the workbook has been significantly updated, and it has not, most of it is more of the look of it. Same with the facilitator guide. If we can take a look at when you received your copy to make sure that it is okay, but there hasn't been any major updates aside from a few additional pages that you could download from the FFS Facilitator website, but we can work with you to take a look at that just to make sure that you have the version that would work with all the programming. But the latest update was more of the look. The cover of it looks a little bit different, but you can still continue to use the supply that you have on hand. Other than that, I wanted to open it up. So if you want to ask a question, remember to unmute yourself. You have to hit *6. All right, I'm not hearing any questions. I do want to say, as a follow-up to this webinar, we will send out an email to those of you that are on the webinar, and it will have a copy of the slides that we showed you today, along with the new facilitator agreement that Ashley was speaking of, and a link to an evaluation survey. To complete the recertification process, it's required that you'd complete that evaluation survey and review, sign and date that new agreement, and you can send those back to me, and that all will be stated in the email. And from there, I will forward those new agreements, the signed agreements, to your local contacts, and then there'll be an additional email that follows up just to complete the entire process. But we appreciate everybody joining the call today. I apologize for the technical issues we had on the front end of the call. Again, we will make the slides available. And if you have any other questions, you can let us know. You can email your local contacts, or you can email me as well, carrieschneider@lung.org. But I thank everybody for joining us. I'm not going to keep you any longer, but have a good rest of your afternoon.